Hello and welcome to this program titled An Expert Panel on Severe Asthma, From the Epithelium to Better Patient Outcomes. We are honored to have participants from across the country here this evening, not only in this room, but also viewing online. This activity is supported by an educational grant from AstraZeneca and provided by Integritas Communications. Everyone in the live audience should have the following items at their place setting: a card with a QR code, which will give you access to program slides, accreditation and disclosure information, as well as a library of valuable clinical resources. A two-sided program evaluation form. Please be sure to complete and return this form to the ushers at the conclusion of this program in order to receive credit. A keypad to respond to polling questions throughout the program. Your responses are anonymous and very important to the educational outcomes of this program. For everyone joining us at home online, all this information is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. Now, let's give a warm welcome to our presenters, Dr. Jeffrey Chupp, Dr. Najira Lugogo, and Dr. Michael Wexler. Enjoy the program.
Thank you so much for joining us this evening. I'm Mike Wexler, as you just saw. I'm a professor of medicine and director of the Asthma Institute, National Jewish Health, and I'm joined this evening by my two esteemed colleagues, Najira Lugogo from University of Michigan and Dr. Jeffrey Chupp from Yale University, who both of these fine clinicians and investigators run their respective asthma programs. And I've been working with them for a number of years on many of the clinical trials that have really informed how we treat patients with asthma. I'm so excited about our program this evening, which is really going to be an interactive program. And we're going to have a discussion on severe asthma. The title of the program, as you can see, is From the Epithelium to Better Patient Outcomes. And so there have been so many innovations in the management of asthma in the last 7 to 8 years, with development of novel biologic therapies targeting a variety of cytokines that have really changed the way we approach patients with asthma. And there are going to be many novel paradigms which will change the way we treat patients with asthma in the coming years. So it's so important for you all as clinicians to appreciate the complexity not only of the pathophysiology of asthma, but also the complexity of the patient journey in regards to especially severe asthma. So first of all, let's see if our clicker can work. There we go. These are our disclosures. Each of us has worked with a variety of different pharmaceutical companies to help develop therapies and educate patients and providers on their use in patients with asthma. Our goals this evening are really to help understand the pathophysiologic processes that contribute to severe asthma, and in particular, airway hyperresponsiveness, mucus plugging, airway remodeling, and we'll talk about the implications of all of these for asthma treatment. We'll also discuss the clinical profiles as well as the evidence for the novel biologic therapies that have helped us address a variety of aspects of severe asthma in patients with this debilitating disease. And lastly, we'll talk about how to tailor treatment regimens for severe asthma to account not only for underlying disease processes, but also to help overcome the barriers related to the use of biologics. So before we start, I'd like to share with you a couple of pre-test questions, and we'll be able to look at the answers for the first few. Let's start off. I don't know if each of you should have a pad at your table. Do they all have pads at their table? Yes. Okay. Approximately how many patients with severe asthma do you manage each week? None, 1 to 5, 6 to 10, 11 to 15, 16 to 20, more than 20, or you don't practice medicine. That's okay too. All right, there we go. So about 25% of you don't practice medicine, that's okay. But there's a large number of you who are seeing patients with asthma on a daily basis. And that's what we're here to discuss. We're going to discuss what your approach should be. And I think one of the things that's going to come out of this is you want to evaluate what type of asthma each patient has. They have severe asthma, non-severe asthma, type 2 asthma, non-type 2 asthma. Those are some of the important questions that we're going to tackle. The next question. All right, here's another question. We have 5 questions, by the way. How many of your patients with severe asthma are receiving maintenance oral corticosteroids for symptom control? So if you have patients with severe asthma, how many are on oral corticosteroid therapy on a routine basis? None, 10%, 20%, 30%, 40%, greater than 50%, or I don't practice asthma, practice medicine. All right, let's see what people said. Wow, so a third of you have none. About close to 20% don't practice medicine. But 47% of you have as many as 30% of your patients who have asthma receiving oral corticosteroids. Out of curiosity, what are your percentages? Nigeria, what percentage of your patients are oral corticosteroid dependent?
Probably 30%.
Wow. And Jeff, what about you?
I'd say 10 to 20%.
Yeah, for me, it's around 10 to 15%. I have to say, we do a very extensive workup at National Jewish Health, as I'm sure my colleagues do as well, to try to evaluate other causes for severe asthma to get patients off of their oral corticosteroid therapy. All right, here's another question. Lung scans of adults with severe asthma from the ongoing Severe Asthma Research Program, or the SARP program, were longitudinally analyzed, and results reveal which of the following. Less than 50% of patients had a mucus plug score of 1 or more at baseline. Mucus plug scores correlated negatively with FEV1. Mucus plug scores correlated negatively with inflammatory markers, or none of the above. Again, these are patients with severe asthma in this Severe Asthma Research Program. Okay. Another pre-test question. This is a 25-year-old gentleman with early onset allergic asthma, and he presented with symptoms that were uncontrolled with anti-IgE therapy, high-dose ICS-LABA, tiotropium, 30 milligrams of prednisone daily, and frequent rescue inhaler use. But he was still reporting that he was adherent to all of his medications. But he also reported that he had 2 emergency room visits for asthma exacerbations within the prior 6 months and 1 hospitalization. When phenotyping him, we evaluated that his blood eosinophil count was 200, his Ig was 650, and his pheno was 20 parts per billion. Which of the following is the least appropriate next step? Discontinue the anti-Ig and initiate anti-IL-5. Discontinue anti-Ig and initiate anti-IL-4 receptor alpha therapy. Discontinue anti-Ig and initiate anti-TSLP therapy. Increase the prednisone to 40 milligrams daily, or add on a macrolide antibiotic. Okay. Don't worry, we're going to go through these questions a little bit later on. Last pretest question is, how frequently do you currently utilize disease phenotype, and biomarker levels to inform biologic treatment selection. Never, 25% of the time, 50% of the time, 75% of the time, 100% of the time, or I don't practice medicine. All right, great. All right, well, our next session is one that I'll lead. It's going to revolve around the burden of severe asthma. There are a lot of patients with asthma in the United States, over 25 million patients who have asthma. There are over 1.5 million emergency room visits, and there are over 300,000 hospitalizations for asthma every year. And we spend a lot of money. If you include direct costs and indirect costs, we spend over $80 billion a year. But I want you to hear from a patient who's going to talk about the burden of severe asthma. And so let's take a listen to Wendy's story.
Hello, my name is Wendy Page. I was diagnosed with asthma in approximately 2009, and I am currently 59 years old. Initially, my symptoms started with what I thought was a cold. 6 to 12 weeks later, I thought I still had a cold. I went to the doctor. They told me that I had bronchitis. I've never had bronchitis in my life. 3 months later, I was sent to see an asthma doctor who told me that I had asthma. I was asked what was asthma. I never had asthma. No one in my family had ever had asthma. I was given some pills. I was given a bronchial dilator. It wasn't well explained to me. And I was just taking medications and really didn't even know how to properly take it. I started off with maybe 20 to 30 milligrams of oral medication. I wasn't improving at all. The emergency room visits, hospitalizations got worse to the point it was every single week. I would go to the emergency room and would get admitted every single time. I didn't know what my triggers were. It had got that bad because I had to have treatments every 4 hours around the clock. So I was just on multiple inhalers, nebulizers. Around this time, I was on 60 milligrams of oral steroids daily. I would get on it and get tapered down, and every time I would get tapered down, by the time I tapered down from like 60 to go down to 10 milligrams, I would go right back in the hospital. I was in ICU multiple times. I had started getting allergy injections. So I was getting 4 allergy injections once a week. So I would go once a week, every Friday, to get 4 allergy injections because I was tested and I had so many allergies. So I was getting allergy injections, and then they tried a biologic, and that wasn't working. And I was on them probably over 10 years before I got on the biologic. So if your cold would put me in the hospital. If my grandchildren came around, if they had a cold or RSV, I was in the hospital. I would catch the flu, pneumonia, you name it. I ended up in the hospital. Every little thing flared me up. I couldn't go a whole lot of places. Like I like to go to concerts, outdoor things. I couldn't do a lot of things because I couldn't go around a lot of people because of my immune system. My body went through a lot. Losing hair because some of the medication, you lose hair. My skin got thin. My nails were brittle. My hair was brittle. Some of the medications made me depressed. Some of them made me not want to do anything. They gave me poor quality of life, like I didn't want to get up because I just knew that this was going to be another day that I was going to have to get up and take all these medications. I couldn't go up and down the steps because going up and down the steps was a chore for me. You can't do your hair, wash your hair, you're out of breath. You can barely stand up and cook, you're out of breath. It was that bad. So it really affected my quality of life. I was on 3 or 4 different biologics before I finally found the one that worked for me. They all didn't work for me. I just kept saying, I know there is one out there for me. And I finally found one that was really helpful and helped me to cut down on my steroid dose. And so I was just glad that I remained positive. I was glad that I just didn't give up on myself. I kept saying, I just can't give up. With the procedures and the next biological, it was magic. I just couldn't believe the difference. And like, I would almost wait for me to go to the hospital. Like, something is wrong. I haven't been to the hospital in a month. I can't actually tell you the last time I had to go to be admitted for just an asthma attack, because I just don't remember, because it has worked just that good. So my asthma is finally controlled really, really well. Do I still carry my inhalers with me? Of course I do. Do I have an EpiPen with me? All the time. So my lungs are not tight like they used to be. I will just close down in an instant. I don't close down like that anymore. And I am learning to live with asthma. I still do everything that I want to do, but that biologic and that surgery, the surgical procedure has really changed my life. So I just want people to know that you can still have a quality of life and have asthma. You can have asthma, but asthma does not have to have you.
She's my patient.
Oh, is that right?
So, Wendy's story is really similar to the lives of many stories that we see of patients with severe asthma. She has so many insights into the journey of our patients with asthma, the suffering, the multiple medications. So let me ask you guys, what are your thoughts on Wendy's case? And do you often manage patients like her in your practice? Jeff?
Absolutely. I mean, I think this is, one of the classic stories. And we know that it was years before she really, got the help she needed. And I think, one of our goals here, one of our messages is that we really know that if we can identify people like Wendy sooner, then, they don't have to go through what they went through. Yeah. And we're probably going to improve long-term outcomes if we do that. So there's benefit in both for the patient in terms of quality of life, but also for their ultimate outcome clinically.
Not to mention healthcare economics and the amount of money we spend on our patients with severe asthma. Najir, what are your thoughts on Wendy's case and the kinds of patients that you see that are like her?
Well, I think she's unfortunately a classic severe asthma clinic patient. There are still some more straightforward, clear-cut biologics patients that happen to find their way to the asthma clinic. But for the most part, I'm seeing patients like this, multiple biologics, oral steroid dependent, and really with so many comorbidities. And so taking care of a patient like that has to be a passion, and you have to be really willing to go all the way with them, because you're pretty much the one person they have. And you really have to develop a relationship and some trust and help patients like this,
Yeah, I think her story really highlights the complexity of the patient journey in patients with severe asthma. They go through multiple medications. You need to do an extensive workup. You need to evaluate biomarkers, try one therapy. Not everything works all the time. And the complexities of the patients, particularly the patients with severe oral steroid-dependent asthma, are even more burdensome.
Yes.
All of the side effects of corticosteroids over the short term and over the long term can really be challenging for our patients with asthma. The other important component of this case really relates to the disparities in biologic use in the United States and really around the world. It's interesting, it's been evaluated that the patients with the highest rate of biologic utilization are white adult females, people with annual incomes of over $75,000 a year, and who are managed by specialists. But what's more interesting to me is the gap in care and the disparities in the biologic use. The patients with the highest rate of asthma mortality, the highest rate of emergency room use, really is in Black adult females like Wendy. Black, Hispanic, Indigenous individuals in the United States, they face the highest burden of asthma compared with white Americans. They have more hospitalizations, more emergency room visits, and they also have greater asthma-related mortality. So it's become clear that there is a gap in the number of patients receiving biologics and those who would benefit from these therapies. The health disparities that persist in asthma are quite obvious, and it's really the severe, poorly controlled asthma patients that are in the Black and Hispanic and Puerto Rican populations. And even though there is an increase in prevalence in asthma overall, this doesn't necessarily account for the significantly worse outcomes in these patient populations. So we have to address these health disparities. We need to address the access to biologics. The reasons for these are multifactorial, but while Black and Hispanic patients only represent about 5% of clinical trial participants, there is certainly a lack of diversity in terms of the utilization of biologics in our patients with severe asthma. So to highlight why we need to consider biologics, we're first going to talk about the underlying biology. We'll talk about what causes asthma at the tissue level. So I'll ask Jeff Chupp to talk about the airway epithelium, which is the first barrier of defense in the airways, and he'll talk about severe asthma pathophysiology. Jeff?
All right, thank you, Mike. So my charge here is to talk about the biology, and I think Wendy's story is a perfect setup for this discussion because you can see that at the tip of the iceberg here are Wendy's symptoms. And she has a lot of symptoms associated with wheezing, shortness of breath, responding to prednisone that becomes prednisone dependent. But when you start to dive into the underlying mechanisms here, you see that what we're going to talk about is that there are some commonalities with all patients with asthma, but there's also a lot of heterogeneity. And that is why Wendy cycled through multiple biologics. And it's not really just a one-size-fits-all kind of disease. And so it's really important that you understand some of this biology that we're going to go into so you can really understand when to select a certain drug for a certain patient, and you pair them up, really ultimately pursuing a personalized, more precise approach to prescribing these medicines, which I think is one of the exciting things here too, is that we're not just handing steroids to everybody anymore, but we're really fitting the right drug for a certain patient. So let's frame this on another case. This is Miss Sanchez. She's 25 years old. She's allergic and atopic since childhood. She has asthma symptoms that have been more frequent in the last 6 months, so a common reason for referral to an asthma program. 3 ER visits that resulted in prednisone tapers, and now is on, again, 20 milligrams of prednisone for control, and she's been unable to taper that medication Every time she goes down, her disease becomes worse again, just like Wendy. Now, this has resulted in weight gain, of course, which is a very common complaint in these patients and just exacerbates everything in their life, and has been unable to exercise because of her disease as well as the weight gain. When you look at some of her other history, you see her social history is she used to smoke, quit, and was a vapor. Car mechanic is her job, so she knows she has exposures at work, but these are things she can't avoid, of course. She lives with her mother, and there's a dog she's probably allergic to, has hobbies working on cars and motorcycles. She's on high-dose fluticasone vilanterol, so this is kind of high-dose ICS-LABA, LTRA, a antihistamine, prednisone of 20, and she takes albuterol. She has no signs or symptoms of EGPA or Churg-Strauss, and she doesn't have any nasal polyps, but her asthma control score is very low at 13, showing that she's poorly controlled.
By the way, we're going to have opportunity for you as we discuss this. There's going to be 5 minutes where you can prepare questions. So you can write down questions, and we'll come around and review those after each case.
Okay, great. So her vitals are stable, of course. She has some scattered wheezing, erythematous nares, and her lung function here, you can see, is 73% of predicted. So her FEV1 is mildly decreased with a normal vital capacity. And that ratio is 0.73, which we might call that normal, but in this young individual, that's likely low. There's no bronchodilator data there, and her nitric oxide level is 16, which is reduced, right? Which is normal, essentially. So less than 25 parts per billion suggests that there is not a lot of eosinophilic inflammation in this patient, or she's being compliant with her ICS-LABA medication.
And she's on oral corticosteroids as well.
As well,
So
correct.
that may abrogate some of the type 2 inflammatory biomarkers.
Her blood work shows her total IgE level is 720, so she has activation of her allergic immune system, as we'll talk about. Her EOs are 780. This is on prednisone, which is really quite dramatic and does make you think about other etiologies of her associated with her asthma or an asthma variant. But her ANCA and ABPA testing is negative, and she's got a negative PDGF receptor mutation as well. So her hypereosinophilic syndrome workup is not remarkable. So this is likely allergy driven. And her X-ray is normal, but her CAT scan does show some bronchial wall thickening, some tree and bud abnormality, consistent probably with mucus plugging in her small airways, and evidence of air trapping on her expiratory images. She's allergic to grasses, dogs, and cats, which she has in her home, we know, which is contributing to her severity probably, trees, dust mites, and cockroaches. So she has clinically, based on the data we see, very clear T2 high, both allergic and eosinophilic asthma that's systemic steroid dependent. So getting to the heterogeneity of this response here, we see that she's kind of what we consider maybe a high patient these days, right? She's hot. She has both eosinophilic inflammation and allergic inflammation contributing. But this slide kind of highlights the networks that are driving this response. And what you can see at the top of the slide is the bronchial epithelium. You can see the allergens, irritants, viruses that are driving in a response from that epithelial layer. And then you can see that cell there, the DC, that's a dendritic cell. That's your professional antigen presenting cell. And the classic allergic paradigm that you can see there on where it says atopic underneath in red, that's the left-hand side of the slide. You can see that that dendritic cell presents an antigen to a T cell, and that T cell converts from being a naive T cell to a memory T cell, and that T cell produces a specific repertoire of cytokines and is now called a Th2 cell. And on the bottom there, you can see it's defined by expression of GATA3, as well as the classic T2 cytokines, IL-4, 5, and 13. IL-4 drives B cells to produce the IgE against that allergen, for example, dogs here. And IL-5, you can see that arrow going to the center of the slide, the eosinophil that drives eosinophilic inflammation. Now, what's interesting here is this drives the allergic response. So when that individual is exposed to allergen in the future, chronically, that realize the right-hand side of the slide, the non-atopic inflammatory pathways can drive eosinophilic inflammation in patients, independent of allergies. So in this paradigm, what you see here is, again, activation of the immune system at the epithelial layer with the production of cytokines and alarmins, such as TSLP, IL-33, and IL-25. And these cytokines work on both sides of the system, but they can activate innate lymphocytes called ILC2 cells that can produce a lot of IL-5 and a lot of IL-13, but they don't produce a lot of IL-4. So in this kind of situation, what you see is a lot of eosinophilic inflammation, because IL-5 is the canonical cytokine for eosinophil growth and maturation. But what you don't see is the IgE production, the specific IgE production. And in the clinic, we see this. So as opposed to the two patients we saw, Wendy and Ms. Sanchez, those patients have a hot allergic and eosinophilic patients. We also see patients that are eosinophilic without the presence of allergies. So this is the heterogeneity of disease that is really important to understand actually in your patients. And this is why when you phenotype them in the clinic, you do a CBC, an FeNO, allergy testing, and lung function testing to really understand their pattern of expression, because it helps you understand which of these pathways is driving their disease. Because, and we're going to get into this in more detail, we now have the number of biologics that are targeted against a number of the cytokines on both sides of this system. And we don't see a consistent response of every patient based on their pattern of expression. So you really have to understand the nuances in these patients. So for example, in Wendy's case, you can move from one biologic to another with some confidence that you're going to get a response that gets her to the type of control that she talked about at the end of her story. So here are the biologics we have here, matching phenotypes with the different mechanisms of action. And I think hopefully everyone's somewhat familiar with these drugs, except those who aren't physicians in the audience. I know there are a few of you. But we have the first drug, omalizumab, at the top, was on the market in 2004. So that was the first biologic, really directed against allergic asthma. So patients needed to have allergies in order to be candidates for that drug. And then we came up with IL-5 drugs, mepolizumab, where patients had to have elevated eosinophils in their blood. And then IL-5 receptor, benralizumab, dupilumab, against IL-4 receptor alpha, which blocks both IL-4 and IL-13. And then the latest kid on the block, tezepelumab, which blocks TSLP, the alarmin here, and works on both sides of the pathway. So Chronicle is a real-world study that AstraZeneca has done looking cross-sectionally at patients. And what you can see here is data that they've generated looking at cross-sectionally at patients in the biologics era who have been receiving different drugs. And what they did was they looked at some comparison of exacerbation rates in patients who were treated with biologics versus anti-IgE, the first biologic which started in 2004, and then patients were switching to other biologics. And what you can see here is there was a significant reduction in exacerbations in patients who were treated with IgE versus pre-treatment rates after they were switched, and then other biologics, similar numbers. So basically, it shows you that all of these biologics have worked well, and patients have had a significant reduction in exacerbation rates, regardless of the biologic class. Now, one of the reasons we're so interested and excited about these drugs, and I think Wendy highlighted that, is that systemic steroids have a number of toxicities, and I think Wendy elegantly talked about some of the nuances that she experienced and made her really miserable. But here you can see the list of things that is really, I think, damaging to patients, some of which are annoyances, but what you can see is the insidious ones that occur over time, like osteoporosis, depression, anxiety, cardiovascular disease, MIs, renal impairment, even sepsis. All of these things are increased in patients who take systemic steroids. And what's important to appreciate is that we know now that this is from cumulative dosing. It's not just from people who chronically take steroids. It's actually cumulative over time. So people who take bursts of steroids multiple times over years have increased risks of these outcomes. Now, another study that's tried to kind of look at this kind of question about the burden of OCS and severe asthma is a study by Tran and colleagues published in JACI in Practice. This looked at a large EHR data set, claims data set of patients between 2012 and 2017. And basically, there were almost 500,000 patients. And what you can see here is that there was a large number of patients in that period prescribed systemic steroids, and 20% of those were on high doses within the time frame of the study. So the burden of use of prednisone in our country, while our chronic use may be 10 to 20% by Mike and I and higher in Najira's practice, there's still a large amount of steroid being used overall, and that's leading to the morbidities that I showed in the previous slide. So there's a lot of studies in biologics, and one of the exciting things was how they studied the ability of patients to reduce or eliminate systemic steroid use. And this just kind of outlines that here. Omalizumab in the Experience study. One of the classic trials that was done was mepolizumab, the Sirius study, published by Hector Ortega in the New England Journal of Medicine, and received an award from ATS for trial design. Ponente, which was an observational prospective study of benralizumab reducing systemic steroid use, dupilumab in the Venture trial, as well as tezepelumab reducing. So all of these drugs have the capacity to reduce or eliminate systemic steroids in patients. And one of the reasons why it's so important to find these patients quickly and get them initiated on therapy. So here's a polling question. 25-year-old female, this is Miss Sanchez again. What would you do based on what we've talked about? She's atopic and allergic with severe disease, prednisone dependent, IgE of 700, EOs of 780, on prednisone. Which biologic would you consider for this case? I'm getting pretty close. bottom? Did I
Yeah.
blow by him?
Yeah,
Oh, jeez.
it's okay.
All right, this is
you go.
interesting. So a quarter of you would do anti-IG, another quarter would do anti-IL-5, 15% would do anti-IL-4, and 40% would do anti-TSLP.
Okay.
What are your guys' thoughts on these? What would you choose?
Well, you know, I think in the current era, you know, all of these options are, I think, viable. And that's one of the things I do like about the answer, the polling answer, because I think that this is also what we see looking at kind of market data or of use of these drugs. It's pretty balanced, fairly balanced across physicians. So there's a good chance that any of these drugs would work. I think probably in this day and age, I'd probably, you know, move towards the, you know, anti-TSLP with the hot patient or the anti-IL-5.
I think it's a reasonable approach. It's probably what I would do as well. When you've got elevations of multiple biomarkers, I think that's a reasonable thing to consider. And with a patient like this who had elevations in both IG, frankly above the cut point for anti-IG therapy, and patients who've got elevated eosinophils and who are steroid dependent, you need to get them off of the corticosteroids. So the data that we showed you suggests that there's a significant benefit of many of these biologic therapies in terms of facilitating corticosteroid withdrawal. So what was chosen, Jeff?
Well, she was started on an anti-IL-5 biologic, which I think is totally reasonable. At 3 months, exacerbations had ceased. She was tapered to 15 of prednisone. Not too aggressive a taper, I'd say. Probably may have been a little more aggressive, but that's totally reasonable. ACT score went to a level of control. EO's down to 50, as you'd expect on an IL-5 drug. IgE still elevated, but that's not something we'd actually check probably again. And at 12 months, she's even better. So really nice to see that kind of reaction. I think we have some questions coming in.
Oh, great. All right. So if patient 1 had nasal polyps, would that have changed your management or your choice of biologic? That's a great question. I think patient 1 refers to this patient, I think. So what are your guys' thoughts? Would nasal polyps change your management?
Yeah. Well, I tend to follow the indications, right? Because that's where the evidence is, and that's also generally the most efficient way to get things through approval processes with insurance companies. So we know that multiple of these drugs have been approved for nasal polyps as well, anti-IgE, anti-IL-5, as well as dupilumab. I think in the clinic, most of us would consider dupilumab, you know, generally has the most robust effects in nasal polyposis, and when you have that comorbidity, I might have switched to that first, although we know that with Tezi as well, there's probably going to be, we're hopeful data is going to come down the pike in nasal polyposis for that drug too.
I'm pretty worried about someone who can have 800 eosinophils on oral steroids. I think that you know, ANCA-negative EGPA is really what most pulmonary people see. The vasculitic type of EGPA, and Mike is here, he's the perfect person to have up here about that. You know, the more vasculitic manifestations like you know, skin manifestations and neurologic manifestations probably end up in rheumatology. So EGPA patients tend to sort of segment into different groups depending on what their manifestations are. They access the healthcare system in multiple different ways. Either she's not taking the prednisone, maybe, or the really high eosinophils would worry me. And in the absence of a high pheno and with a really high eosinophil count, high IgE, I'd be a bit worried about dupilumab. It doesn't deplete eosinophils. It increases eosinophils transiently, actually. And in people who are extremely eosinophilic, it can be a little bit, more risky. You have to actually monitor the patient a little bit closely and such. So I don't think it's an unreasonable choice, but you would really have to check the eosinophils repeatedly, very closely, monitoring the patient to make sure they don't develop an EGPA type presentation. With regards to nasal polyps, I think you have to think of them in two ways. So they are nasal polyps that predict a very high T2 phenotype, and they happen to be there. They tend to predict a very good response to pretty much every biologic. And then there are nasal polyps that are causing a problem, and you're attempting to treat the nasal polyps. So some people have nasal polyps, about 25% of severe asthma, but many have one polypectomy, and then they go about their business with topical steroids and they're fine. In that case, I would use the nasal polyp as a treatable trait. It would inform me about the extent to which someone is T2 high, but I might not incorporate it into my treatment decision because the patient doesn't actually have a current major problem with nasal polyps. So I think you have to really think about whether you're including it as a treatment target, or you're including it as a predictor of response and a disease phenotype.
Yeah, so I'll just say a patient who's on oral corticosteroids who continues to have nasal polyps and continues to have eosinophilia of over 700, there are 3 drugs that are indicated, as Jeff mentioned, for nasal polyps, chronic sinusitis nasal polyps: mepolizumab, omalizumab, and dupilumab. This patient who's got high eosinophils and nasal polyps, mepolizumab might be a reasonable choice. There are other therapies. Tezepelumab, while not indicated for that, for nasal polyps and chronic sinusitis, in the Navigator study, patients who were treated with anti-TSLP therapy had a significant improvement in SNOT-22, and patients who had nasal polyps and chronic sinusitis, they had a particularly great improvement in their asthma exacerbation rate. A couple of other questions came. What about the role of LAMA in this patient? What are your thoughts? Would you have added a LAMA pre-biologic, in addition to biologic? What are the benefits there? Let's do these as rapid fire questions since we just got a couple of minutes.
I definitely would go to triple therapy before, but generally speaking, like a patient comes to me with this disease, I'd start the triple therapy and order the biologic at the same time, because I know that it's probably not going to get us where we need to go. It's going to help, but won't get them off of prednisone.
I agree.
Yeah, so there are some benefits, and adding a LAMA like tiotropium has been shown to reduce exacerbations, improve lung function, but nowhere near the same level of reduction in exacerbations as with the biologic therapies. A couple of other quick questions. Well, I don't know if this is such a quick question. What could be possible solutions to health disparities in asthma? And are there any holes in environmental policy that need to be addressed? Jared, quick answer.
Yes.
You've given like hour-long lectures on this, so let's hear. Tell me all the solutions to healthcare disparities.
Well, I'll give you one simple solution, which is don't make assumptions about people that don't look like you. Because oftentimes if you treat people equitably and meet them where they are and assume that they are actually taking their medication and they actually are trying their best and not really making a lot of assumptions, I think you'll give a lot more people the therapy that they need. We need some policy changes for sure to help with climate change and all that. But all I can say is tackle the person sitting right in front of you.
Yeah. I think a lot of the issues with healthcare disparities relate to actually access to care, access to medications. There are a lot of patients who actually don't even present to physicians with the issues. How would you know if someone's got blood pressure if they never have their blood pressure checked? How would you know if someone has asthma if they never come in to see a specialist? So it's important to address asthma as an important condition that these patients face.
I'll add to that too, just for a second, because, I think totally agree with you, of course, but mine is have an open door policy.
Yeah.
Oh, yeah.
And, force your institution, if you work in an institution, to have an open door policy. If there's a patient with asthma that needs to see you, I don't need a referral packet from another physician. I don't need any information. Get them in here, we'll get things started, and we'll figure out what's going on.
And I think the other issue in terms of solutions to healthcare disparities is lowering the cost of medications. There's already been a movement by Congress to lower the cost of asthma inhalers, now down to $35 a month, which some people still can't afford, but it's better than $50, $100, $200 a month. In terms of environmental policy, we need to do better in terms of addressing environmental issues, in terms of addressing smog and other climate-related changes which can have an effect. And then before we go on to the last question, this is what % of severe asthma patients stay controlled on anti-IG therapy alone? Do you have a sense of that? What's the response rate to anti-IG therapy?
Good question. Well, if you look at the study that kind of parallels our current, the impact study that Nick Hanania published, it was about 25% reduction in exacerbation rates based on, prednisone use. That you can get that up to about 50% if you include both allergy as well as a high FeNO level. So I think you can achieve those kinds of rates. I think in our general consensus, however, is that it doesn't have much of an effect on lung function overall in terms of the data. And it's not, it requires a lot of injections potentially in a lot of patients, right? 3 injections every 2 weeks on high dose.
But there are a lot of benefits in terms of reduction in exacerbations, as well as benefits in terms of urticaria and sinusitis. So one other thing that we're going to just highlight in the next section is asthma isn't just about reduction in lung function and low FEV1. It's not just about exacerbations. One of the things that bothers patients is twitchiness of their airways. And what Najira is going to talk about next is the concept of airway hyperresponsiveness and also the importance of mucus plugging in patients with severe asthma. Najira?
Thank you so much. So we'll start with a case here. This is a 62-year-old male, and he has adult onset asthma. Persistent shortness of breath, cough, sputum that began during the peak of his marathon running days, and he hasn't really been able to do that anymore. Initially was on ICS/LABA, exacerbations continued. He got prednisone for that. 12-month trial of omalizumab 10 years ago, and the exacerbations did not improve, so he discontinued the medication. He took dupilumab 8 years following the omalizumab trial, moderate improvement in cough, persistent shortness of breath with running, asthma exacerbations twice a year requiring prednisone. He's a never smoker, former marathon runner, musician, takes dupilumab currently, high dose ICS/LABA, montelukast, tiotropium, and albuterol, and currently has an ACT score of 19. Really, the notable things here are his low lung function with no bronchodilator response. If you haven't seen the recent JACI publication, it just came out about the prevalence of bronchodilator response in the community. It happens to be about 18 to 20% and does not differ between asthma and COPD. So I personally am putting in a plug for not relying on bronchodilator response as a diagnostic criteria for asthma. He has a low FEV1 FVC ratio, no air trapping, a FeNO of 25, which on high dose ICS/LABA is considered elevated. He has IgE of 100, eosinophils of 190, ANCA negative, positive skin prick tests, and high-res CT findings of air trapping, mucus plugging, right and left lower lobe plugging that's noted on imaging. And then he had an endobronchial biopsy that showed basement membrane thickening and fibrosis, goblet cell and mucus gland hyperplasia, and increased smooth muscle mass and inflammation. I have to say that's an impressive histology report. Mine is never that good, but hopefully you have a very good pathologist. I think that Jeff has a very good pathologist. So what's your impression of the case? How do you determine whether patients have an adequate response to therapy here, Jeff?
Well, I think this, gentleman had been doing, better, but clearly he had traveled actually a long way to come see me, and he wasn't where he wanted to be. So he showed up for a reason, and you could see his ACT score was 19, and he didn't quite have his quality of life back. So he had some improvement in his, with the therapies he was using, but he clearly needed more. And this is, I think, one of the nice things about the evolution of our business is that we now have multiple options. So you have to recognize this, because he could easily, I think he had slipped through the cracks for a long time, assumed to be pretty well controlled, and that was good enough. And we have to be more aspirational, I think, for our patients now.
So what do you think?
I think he highlights sort of the heterogeneity of the presentation of patients with asthma. And he clearly has airflow obstruction. His FEV1 is 62% predicted, but he doesn't have any of the classic elevation of type 2 biomarkers. Yes, his eosinophil counts are above 150, but 190 isn't that high. His IG is not that high. His pheno is 25. It's not that high. But yet we see on imaging that he's got mucus plugs. And that bespeaks the importance of other factors that may contribute to airflow obstruction, like mucus plugging. And you can see that on histology, you can see it on imaging, and you know about it because that's what he's reporting clinically, and his FEV1 is low. It's the mucus plugs that are causing the reduction in his lung function for sure. And whether or not he's got the type 2 biomarkers at this point, or whether he just has significant mucus plugging that's contributing his asthma from a variety of other reasons, that's clearly what needs to be addressed in him.
Yes, and it is quite important to remember that response is multimodal. So there are multiple ways in which people respond, and you are looking for exacerbation reduction, OCS sparing, asthma control, lung function improvement. You're looking to get him back running, because that's what he wants to do. So you want the patient's goal to be incorporated as well. And so you really need to think about all the different ways in which people are supposed to respond, and sometimes they respond in some but not other ways as well.
Yeah. I think the other thing that, we're concerned about here is that, he's been on a lot of treatments, and yet he has an FEV1 of 62% without bronchodilator responsiveness.
Yeah.
And your concern is that this is remodeled.
Right.
And that you're never going to get that up.
Right.
Right?
Right. Absolutely.
Or that's what we believe, because that's kind of how it's been for a long time for this gentleman.
Exactly, exactly. And so, when we think about asthma, Jeff covered the epithelium quite well. And that's really important because the epithelium and the epithelial barrier is really key in starting the inflammatory cascade. But we have to remember that outside the airway is the airway smooth muscle. And it has functional reasons for being there, but in people with asthma, it can be dysregulated. It can be bigger than it should be, and it can be quite hyperresponsive. And so with patients that have asthma, you can have the inflammatory component. Sometimes the inflammatory mediators actually spill over into affecting airway hyperresponsiveness, such as IL-13. And the mast cells, those play a significant role in airway hyperresponsiveness. Airway hyperresponsiveness contributes to airway narrowing, but of course on the inside of your bronchial tube are inflammatory cells, mucus plugging, and so forth that can also contribute to narrowing. And so this increased airway smooth muscle tone is what we are treating with bronchodilators, but you have to remember, for instance, if you have high IL-13, you won't be, people who have high IL-13 aren't going to be as bronchodilator responsive, for instance. And so all these things really contribute to narrowing. and hyperresponsiveness, some of which is irreversible. At least we thought it was irreversible in the past, and I think we aren't quite sure anymore. Some of these patients improve slowly over time. Now, he had some things that hinted towards remodeling with the basement membrane thickening and the increased smooth muscle mass, and that may certainly indicate that there is some remodeling happening here. And so what is mucus plugs? And I had to actually learn a lot about mucus plugging. We participated in a clinical trial with mucus plugging. I used to think about mucus in the same way as I thought about sputum. And it turns out that mucus and sputum are actually quite different. And sometimes people who produce a lot of sputum don't really have a lot of mucus plugging. So the mucus plugs are very thick, viscous secretions. They tend to be eosinophil rich. They are a product of IL-13 mediated inflammation, eosinophil exotasis, and eosinophil degranulation, and EPO all cause this cross-linking to occur with Charcot-Leyden crystals that we remember learning in pathology in medical school. And it leads to these very viscous and thick secretions that tend to persist in particular airways over time. And there's data from SARP showing that mucus plugs tend to stay in the same airway over a 3-year period. So whether there's something in the microenvironment is unclear, but there seems to be propagation of mucus plug in particular airways. It is very IL-13 mediated, related to MUC5AC expression. There's loss of ciliated cells and increased thiocyanate transport. And of course, eosinophils and granule proteins play a very important role in mucus plug formation. So this is our polling question, which is how frequently do you consider mucus plugging as a relevant finding to inform biologic treatment selection? Never, 25% of the time, 50%, 75%, 100% of the time, or I don't really manage severe asthma. Okay, so it seems like 43% never. And I hope that when you leave here today, you'll start thinking about mucus plugs. It turns out once you think about mucus plugs, you see them. And so what about you, Jeff? Do you look for mucus plugs? Is it something that helps you think about what biologic to pick?
I think it used to be never.
Okay.
But I think it's been evolving.
Yeah.
We don't have specific data showing outcomes related to biologic use prospectively,
Right.
RCT data, but I think that we have some very good data about reduction in mucus plugs in, the trials.
Yeah.
And that this may be a good phenotype for us to focus on. It also makes me think of other things that may be going on with the patient. As well. It might inform our workup a little differently in terms of considering a bronchoscopy, lavage, AFB, things like look for MAC.
Looking for infection.
Stuff like that.
Yeah, there have been a number of imaging studies over the last couple of years that have been published that have suggested that use of a variety of different biologics, particularly mepolizumab, benralizumab, dupilumab, and tezepelumab, have been shown to reduce mucus plugging on imaging studies. And for a patient who has mucus plugging, I also didn't consider it a few years ago, but now I consider it one phenotype that requires additional consideration. Yeah. And if someone is continuing to have symptoms on a single biologic, I might switch them to another biologic that's been shown to reduce mucus plugging.
Now, it's important to note that a mucus plug score is really a complete occlusion of the subsegmental airway. There are 20 of them. You have to fully occlude the airway to get a score of 1, and then you count each of the 20 subsegmental airways. And so a score of 0 is 0 mucus plugs. A low score is up to 3.5, which means you have about 3.5 or so less than 4 plugged airways, and a high mucus plug score is between 4 to 20. Now, greater than 50% of patients in the severe asthma research program had a mucus plug score of greater than equal to 1 at baseline, meaning that mucus plug scores are not rare phenomenon. Now, there are people who have extremely high scores. These persisted over time. They don't respond, by the way, to oral steroids. You cannot get rid of mucus plugs by using oral corticosteroids, but they do respond to targeted biologic therapy. And then there was a 10-fold higher occurrence of an FEV1 less than 60% in people with plugs. So they are clinically consequential, and they are also associated with just a more severe asthma phenotype. And so I think mucus plug scores are going to really start becoming a phenotype that we think about, and based on what you both said, you're starting to think about this as informing treatment selection. So how can biologics affect mucus plugs? This is a study that we recently completed, and it's actually coming out hopefully shortly. And essentially in this trial, the patients had high nitric oxide levels and high eosinophils. So you have to remember these were T2 high patients, 300 eosinophils, nitric oxide greater than 35 parts per billion. And what we wanted to do is really understand whether A, we could use dupilumab to suppress the pheno levels, and then B, whether there could be a % change from baseline in image-based volume. So were the mucus plugs that were present causing some downstream consequences? So a lot of the patients achieved the pheno less than 25 parts per billion compared to placebo. We did notice a significant improvement in mucus plug scores with dupilumab compared to placebo. And also consequently, there was an improvement in airway volumes and also a reduction in airway resistance. So these plugs are actually clinically meaningful. And so this is another study. This is tezepelumab, and the first figure shows you the overall mucus plug score reduction, which was 1.7. But when you enrich the population for T2 high patients with EOs greater than 300 and pheno greater than 25, you have a reduction from 7.2 to 0.4, which is a 94% reduction in mucus plugs over time, and so it's quite important. The other thing is that there was a significantly greater reduction in airway submucosal eosinophils, which is quite important as well. So mucus scores are correlated positively with inflammatory markers and negatively with lung function. As you remember, there was a question about this at the beginning, so hopefully all of you will get it right when you do the post-test questions. And then lastly, what about airway hyperresponsiveness? Now, airway hyperresponsiveness has been studied in multiple challenge tests, both including methacholine and histamine, and the results are a little bit variable. And findings across biologics suggest that inhibition of T2 reason.
So we have both of those tests available in our center. They have some slight differences. I don't use them a lot in our practice unless I'm focused on trying to make a diagnosis of asthma with somebody with atypical symptoms and normal lung function.
Okay.
In patients with asthma, generally who are being treated, I think there's a lot of issues with the effects of drugs they may be taking that I find airway hyperresponsive is not generally that useful a test.
Yeah, I get at the question of airway hyperresponsiveness clinically, and you can oftentimes arrive at a evaluation of airway hyperresponsiveness by just asking patients, do irritants in the air, perfume, smoke, cause smog when it's smoggy? Does that cause you to cough, to wheeze, to have chest tightness? I usually utilize airway hyperresponsiveness metrics to evaluate whether or not the patient has asthma. That's the first step if they don't have classic history or bronchodilator responsiveness, or if they come in with a story of asthma that I don't believe, or that I'm trying to ascertain, and they don't, they might have normal lung function, then I wouldn't expect them to bronchodilate. I might use airway hyperresponsiveness to evaluate whether or not they have asthma. For me, that's one of the first questions that you should be asking when you see a patient with severe asthma. One is, do they have asthma? Second of all, do they have other complicating factors? Third of all, are they adherent to therapies? And then once you evaluate all those things, I want to know what type of asthma they have, and I evaluate their biomarkers.
Great. So this is some data on airway hyperresponsiveness, and the two studies here are the upstream and the cascade studies. And the primary outcome is the doubling dose in the PD15 in inhaled mannitol for upstream and AHR2 mannitol for the cascade studies. And what you'll see is that AHR2 mannitol improved in patients treated with tezepelumab versus placebo. Although not significant in upstream, it was actually significant in the cascade study. And why do we believe that tezepelumab has an impact on AHR where perhaps some of our other biologics don't have an impact on AHR?
Yeah, one of the things about TSLP is that there are receptors for TSLP on the airway smooth muscle, in addition to the production by the airway epithelium. And the airway smooth muscle also produces TSLP. Mast cells also, which contribute to airway hyperresponsiveness, also play a role in terms of TSLP pathobiology. So because of that, we think that TSLP blockade, whether at the ligand or at the receptor level, might have a significant impact in terms of abrogating airway hyperresponsiveness in our patients with severe asthma. So we have another polling question.
Yes, absolutely. You remember this patient from earlier, and he's persistently short of breath, having symptoms, exacerbations, prior omalizumab failure. Currently on dupilumab, we feel like his response was modest for the reasons that Jeff alluded to earlier. He still has some airflow obstruction, low T2 markers, except maybe the eosinophil count of 190. And high-res CT with air trapping and mucus plugs, a really nice biopsy there with phenotypical findings of asthma. And so what therapy would you consider next? So here we are considering an anti-IL-5 therapy, anti-TSLP therapy, bronchial thermoplasty, or a macrolide. Oh, okay. I think everyone did what Jeff did.
Yeah, I think that's good. So I guess, we're all getting aligned here.
Yes, absolutely.
I will say that bronchial thermoplasty, which delivers thermal energy to the airways, has been shown in animal models to reduce airway hyperresponsiveness. And other biologics, in addition to tezepelumab, including the anti-IL-5s and anti-IL-4/13, have been shown to reduce airway hyperresponsiveness. But tezepelumab has been shown to do it consistently across a variety of different studies.
Yeah, and so this patient did quite well, and I think what I really was quite surprised about, and I really believe this should challenge our thinking about fixed obstruction, is that this patient's FEV1 normalized on therapy, and many of us would have probably said, well, he doesn't have bronchodilator responsiveness, perhaps there won't be a normalization. Did that surprise you?
Absolutely, and I think his primary pulmonologist as well was, in his note wrote, his lung functions improved for the first time in years.
That's
so
amazing.
he was, it was really quite surprising, and it correlated with his clinical response as well. He had improved with the dupilumab, but his cough had gone away. He was less short of breath. He was able to exercise on a treadmill. start running again. So,
Amazing.
you know, it was one of these cases where it seemed like a subtle change in therapy, like or almost a lateral move in certain ways. But, you know, like you said, connect with your patient, you know, really focus in on what's important to them, and you can still improve their outcomes.
I think we like to say now with all these new therapies, we never say never.
Yeah,
And it's been so exciting to see significant improvement in our patients with severe asthma. Another area that's really been exciting is to see the way we've considered the different types of patients with asthma. We've talked about type 2 asthma, the allergic eosinophilic patient. We've talked about airway hyperresponsiveness. We've talked about mucus plugging. Another patient that we see in our asthma clinics are patients who don't have elevation of biomarkers, the type 2 low patients. This has become somewhat of an orphan disease in our clinics. And you know, there was a lot of debate about whether or not type 2 low asthma just reflects use of inhaled corticosteroids or systemic corticosteroids. But we're clearly seeing about 20% of our patient population have low eosinophils, low nitric oxide, and no propensity to allergy. So we'll go through our last case, which is Miss Clark, who is a 57-year-old woman who's referred for severe oral steroid-dependent asthma. And she was diagnosed at age 35. She had symptoms of shortness of breath, wheezing that were uncontrolled with high-dose ICS/LABA, as well as albuterol. She continued to have exacerbations every 2 to 3 years initially, but now it's been once or twice a year, and each time requiring prednisone, despite the fact that she had montelukast and a LAMA added to her regimen. That didn't really change things much. She was on 30 milligrams of prednisone that were added for control of her symptoms, and she reported no history of childhood asthma or allergies. She did have an LPR once a year. Socially, she's a former cigarette smoker. It's interesting because at this ATS, we've talked a lot about COPD and the potential for biologics. She did quit at age 25. She's got a home health aide, no exposures, no pets, lives in a single family home, hardwood floors. She's got 3 adult children. And as I mentioned, she's on multiple asthma therapies. I'd call this the kitchen sink of asthma therapies prior to biologics. She's on a inhaled steroid, a long-acting beta agonist, a leukotriene modifier, tiotropium, she's on albuterol. She takes esomeprazole for her reflux disease. And despite all that, she continues to have a low asthma control test score of 10, when normal is 20 to 25. Vital signs are normal. She's got clear lungs, she's got good breath sounds. But when we checked her lung function, she has evidence of clear airflow obstruction with an FEV1 of 55%, although her vital capacity is also reduced, although still her FEV1 to FVC ratio is 0.93. She's got a total lung capacity of 83%, a residual volume 108%, and we worked her out capacity of 83%, a residual volume 108%, and we worked her out across the board. High-res CT scan was unremarkable. EGD, barium swallow, 24-hour pH probe, all negative. We call this the National Jewish $1 Million workup that she's had so far. And she even had a methacholine challenge, but that showed that her PC20 was 4 milligrams per milliliter. That's the provocative dose of methacholine that could induce a 20% reduction in her lung function. So that suggests she does indeed have asthma that has some degree of airway hyperresponsiveness. So what are your thoughts of this case? Jeff?
Well, I think, you know, patients obviously, you know, has very severe disease and is obstructed, but as you said, she's got, you know, low
T2.
evidence of T2 biomarkers, and we do see this. And you always worry that there is something else going on, right? And so you do have to do, you do have to do that additional workup because reflux is obviously a big thing here. And you might do, you know, we don't, like that last patient, we would might bronch that patient and make sure we did airway biopsies to really see what's going on in the airway wall.
Yeah, bronchoscopy isn't done at a lot of centers, but it is done at some of our centers, and it's so important to consider bronchoscopy to see what's going on in the airways. And when you do bronchoscopies, first of all, you can evaluate the upper airways, you can look for vocal cord issues, you can look for evidence of laryngopharyngeal reflux, for instance. You can evaluate to see whether or not there are abnormalities in the airway anatomy, whether there's an airway tumor. But you can also do biopsies, look at the microbiome, mycoplasma, chlamydia, as well as other microorganisms. And you can also do airway biopsies and look to see if there's evidence of tissue eosinophilia. So, Najir, what are your thoughts of this case?
I mean, I think it's a pretty good workup. And so with the positive methacholine and the testing, I would feel more confident that this is a non-T2 asthma case.
Yeah, the one thing that's missing, we don't have it, nitric oxide. That would be another useful metric to confirm the fact that she doesn't have elevated nitric oxide. And that would be an indicator of IL-13 mediated pathophysiology. So this is a very interesting non-type 2 case. So what drives non-type 2 disease? What are these type 2 low patients? Well, oftentimes we think, and we've come to recognize over the last decade, that a lot of non-type 2 disease is also driven by alarmins. You see the variety of different stimuli that are often associated with non-type 2 disease, whether it's irritants, pollutants, microbes, and viruses. Many of these are associated with non-type 2 disease. Allergens usually with type 2 disease, but many of these are associated with non-type 2 disease, sometimes with both. And one of the key effector cells is the neutrophil, and that is often activated by a variety of different non-type 2 cytokines. You can see that we don't talk about IL-4, 5, and 13 as we did in the type 2 patients. Here we're talking about IL-17, IL-6, IL-8, GM-CSF, interferon gamma, and other TNF-alpha and other non-type 2 cytokines. Those are driven by some of the alarmins, including TSLP, IL-33, IL-6, and IL-23, amongst others. Tezepelumab is one of the key cytokines that blocks TSLP. Right now, there are other therapies that are under investigation that block TSLP, that block the TSLP receptor, that block IL-33, that block IL-6. So it's hoped that we're going to have other therapies that work in this patient population. With regard to IL-6, it's clear that IL-6 plays an important role in terms of both the homeostasis of the airway epithelium, in terms of abrogating infections in the airways, and plays a role in terms of activating neutrophils. It also plays an important role in exacerbations. And there are a variety of mechanisms with indirect activity on T cells, macrophages, and even eosinophils that can play a role. So we have one more polling question here about a 57-year-old steroid-dependent asthmatic, age 35, who was on 30 milligrams of prednisone, ICS-LABA, LAMA, Montelukast, 1 to 2 exacerbations a year, and who had biomarkers that included low IG of 30, low eosinophils of 100, was on prednisone, but still had an FEV1 of 55% and a PC20 of 4. Which therapy would you consider for this type of patient? Anti-IG, anti-IL-5, or a receptor, anti-IL-4, anti-TSLP, or a macrolide antibiotic? Let's hear what the rest of you have to say. Okay. Okay. All right, so interesting. So a lot of you said anti-TSLP. I think some of us, I don't know what you guys think, but I often start a patient on a macrolide antibiotic 3 times a week and then consider a biologic in those patients, or while I'm working them up for a biologic.
I mean, I will say in a patient who's prednisone dependent, in this patient, even though all the biomarkers are low, the one drug that has been studied is dupilumab, right, independent of their EO count. So you could consider that in a prednisone-dependent patient as well, based on the data. So those patient like this might have been included in that trial. So it would be a reasonable consideration.
Yeah. So what happened to this patient was she was started on benralizumab, but still wasn't well controlled. She was started on dupilumab, as you suggested, because she was steroid dependent, and then she was started on tezepelumab. And she had moderate improvement actually after 3 months on Tezi, and she tapered her prednisone down, her ACT score came up. And one of the key things was that she felt better, that resulted in greater exercise capacity and had some weight loss, which also had an important impact on her care. Okay, so I think we've discussed a lot of different factors. We're going to have some time for questions. And if any of you have questions, please fill out your cards and send them up to us. But just to summarize what we've discussed this evening, it's clear that we're in a new era now in the management of asthma. When we trained, 15, 20 years ago, we didn't have a lot of options. We had inhaled steroids, long-acting beta agonists. We started to use long-acting antimuscarinic agents. But more recently, the advent of 5 new biologic therapies in the last 9 years has really had a huge impact on the way we treat patients with asthma. It's been shown to reduce exacerbations, improve lung function, reduce corticosteroid dosing, and now we're starting to think of other phenotypes, including airway remodeling, including mucus production, including airway hyperresponsiveness. So what we advocate to you is really consider the use of these therapies, but do a good workup. Figure out what type of asthma your patient has, and that will allow you to choose the right drug for the right patient at the right time and give the opportunity to offer really precision-based approach for our patients with asthma. So we have a couple of post-test questions. And I'm curious to hear what you have to say, and then we have a couple of questions that we're going to answer here. Yeah. Let's go through the post-test questions first, and then we'll do a couple of questions from the audience. So the Severe Asthma Research Program revealed what from lung scans? Less than 50% of patients had a mucus plug score of greater than 1 at baseline. Mucus plug scores correlated negatively with FEV1. Mucus plug scores correlated negatively with inflammatory markers, or none of the above. What do you think? Okay. Yeah, that's the correct answer, which is mucus plug scores. The higher the mucus plug score, the more mucus in the airways, the greater the airflow obstruction, the lower the FEV1. So mucus plug scores correlate negatively with FEV1. In terms of answer 3, actually there was a positive correlation. The higher the eosinophils, the higher the nitric oxide, the greater the mucus plug scores, and over 50% of patients did have mucus plug scores greater than 1. All right, question 2. A 25-year-old man with early onset allergic asthma who was uncontrolled on anti-IG, ICS-LABA, tiotropium, prednisone, and frequent inhaler use, 2 emergency room visits, EOS 200, IG 650, pheno 20. What is the least appropriate option for this patient? Again, on anti-IG therapy and on prednisone. Okay, so yes, the correct answer is increase the pressure. All of these options are good options that we have here. You can give anti-IL-5 for the eosinophilia and the steroid use and the mucus plugging, anti-IL-4, anti-TSLP. Even adding on a macrolide antibiotic might be considered, although probably the use of the biologics would be an appropriate one in this patient. And increasing the prednisone is probably not a good option unless the patient is having a real acute asthma exacerbation. All right, question 3. How frequently will you now utilize disease phenotype and biomarker levels to inform biologic treatment? Never. If it's never, then you have to leave the room, I'm sorry. 25% of the time, 50% of the time, 75% of the time, 100% of the time, or I don't practice medicine. Yeah, sure. Yeah, but let's do it quickly. All right, let's see what people said here. Okay, 100% of the time. Good to hear. All right, hopefully we'll have an impact. And yeah, you can all stay for dessert. All right, so we have a couple of questions before we thank you all for participating tonight. In case 3, did the BMI of 36 have any impact? Yeah, certainly elevated BMI can have a significant impact on the symptoms of asthma. A lot of obesity can contribute to asthma symptoms. Furthermore, there are systemic inflammatory processes, increases in IL-6 that can contribute to asthma. And so there have been several studies that have shown that weight loss can also improve symptoms associated with asthma. So yes, that could have certainly had an impact, and weight loss can play an important role.
My question comes from William. So in the absence of using bronchodilator response, what then should be the standard for diagnosis of asthma? This is a good one. Since I'm a proponent of getting rid of bronchodilator responsiveness, I guess I deserve this question. I think you should use variability in lung function. If you have excluded other diagnoses and you have high nitric oxide, for example, if patients have lung function that changes over time, such as peak flow variability, that's a good one. If you test for airway hyperresponsiveness, that is actually also not common amongst every asthma patient and can be variable. But I do think you should use multiple different tools to confirm or disprove whether a patient has asthma.
One important thing, in addition to acute bronchodilator response and airway hyperresponsiveness measured by methylcholine challenge, is really looking at lung function over time.
Yeah.
And we've used in several of our clinical trials changes, variability of lung function. Someone who 4 months ago or 6 months ago had an FEV1 of 80% and now is at 60% may not be bronchodilating for whatever reason, or the other way around. They may have been 60% then and 80% now. That might be indicative of significant airflow variability that can contribute to asthma.
Okay.
So I agree with that. I think the important thing is you shouldn't rely on one thing, and reversibility is great when you have it, but it's not the only thing, and especially in the labs. So what we're looking, and I think the guidelines do say this clearly in the definition of disease, is that we're talking about variable airflow obstruction.
Right.
It doesn't always have to be acute. It can be over time. Right. If you have a patient that was treated with a course of steroids and they respond nicely and their symptoms improve, these are the things that help you kind of define variable airflow obstruction in various ways. So my question relates to obesity as well. Peds pulmonary. Most obese patients are not fully responsive to biologics. What is the best biologic agent for obese patients with severe asthma? Well, I think that's a very interesting question. So obesity clearly is a comorbidity associated with severe disease. And in some patients, it's very high, of course. And you have to consider that in evaluating your patient's symptoms. Mm-hmm. And when they don't respond fully, it's often unclear if it's truly a lack of response to the biologic or whether it's residual effects of them having obesity.
Right.
So I think that you have to sort that out carefully. Virtually all of the biologics that we talked about tonight have done post hoc analyses of their data sets and shown that responses to the drug are similar in patients with high BMIs as well as normal BMIs.
Yeah.
So I don't think we can actually say that there's a best biologic for any given obese patient. So I think if we really thought that, we probably would have put that into our phenotyping context tonight. So I don't see I think you should consider all of those drugs independent of their BMI, but more based on their biologic phenotypes.
Yeah, right now, as of
And
today.
we do see, I'll just say, in the high BMI group, we do see everybody associates this with the concept of neutrophilic asthma, but there seems to also be patients with high T2 disease in this group. So that's not, it's not a specific subtype of disease that's associated with low T2 disease.
Yeah, one other phenotype of obesity-associated asthma is, and it's been recognized from the Severe Asthma Research Program, is presence of elevated IL-6 and CRP levels.
Yeah.
And right now, as part of the PRECISE network that all three of us are part of, we're actually studying anti-IL-6 therapies in our patients with severe asthma. I have one last quick question, and then we're going to conclude the evening. People can feel free to come up. But this question relates to Ann Woolcock's review of inhaled steroid treatment of asthma showed different outcomes take different times to improve, and bronchial hyperresponsiveness taking 1 to 2 years. Have the biological drugs been studied for a long enough period to improve bronchial hyperresponsiveness? Yeah, the answer to that is yes, actually. Several of the studies that have been done, particularly the Cascade study, has shown a significant improvement in airway hyperresponsiveness, bronchial hyperresponsiveness in as quickly as in 12 weeks. So the answer to that is yes, the biologics have been shown to demonstrate that. So this is really going to conclude our program this evening. Thank you so much for joining us. We had a great discussion. We had great questions from you, the audience. I want to thank the sponsors of this program, and thank you all for spending your evening with us at a dinner program. And we're happy to take some questions up here, but we hope you have a great rest of your meeting and will join us for future programs. So thank you so much, everybody. Have a good night.